हाँ बोलो मैम।
एक मिनट, आवाज़ आ रही है? हाँ, माइक तो चल रहा है शायद।
मैं यहाँ से 1 मिनट लोकली चेक कर लेता हूँ।
आवाज़ ठीक है?
मैम स्टार्ट कर दो।
स्टार्ट कर दूँ? आवाज़ तो आ रही है ना? ठीक है, ओके। Good evening, dear students. I, Dr. Ami Rawal, your original guru for dental anatomy and dental histology, is here with you to clear your doubts. So, I have got some few questions. We will discuss that questions, right? So, coming to my first question. Masticatory mucosa is orthokeratinized or parakeratinized, right? So, masticatory mucosa is basically a type of oral mucous membrane, right? So, oral mucous membrane is moist lining covering our oral cavity. Based on its function, this oral mucous membrane is classified into 3 types. Which are the 3 types? Masticatory mucosa, lining mucosa, and specialized mucosa. Right? Masticatory mucosa, lining mucosa, and specialized mucosa. So basically, based on their function, oral mucous membrane are of 3 types. Based on the type of epithelium, again they can be classified as keratinized or non-keratinized, right? So based on epithelium, they can be classified as keratinized and non-keratinized. In keratinized, again we have 2 parts: parakeratinized or orthokeratinized. In orthokeratinized, we have granular cell layer, right? So it is asked, our question is, masticatory mucosa is whether orthokeratinized or parakeratinized. So which are the examples of masticatory mucosa? Masticatory mucosa are gingiva and hard palate. Gingiva and hard palate. So what is the epithelium of gingiva and what will be the epithelium of hard palate? Basically, it is keratinized, obviously, right? Both are keratinized. Gingiva is mostly parakeratinized and hard palate is mostly orthokeratinized. Coming to lining mucosa, it is non-keratinized, mostly non-keratinized. And specialized mucosa is also keratinized. So gingiva, hard palate are obviously keratinized. So masticatory mucosa are gingiva and hard palate, which are keratinized. Lining mucosa, remaining part of the oral cavity, such as lips, cheeks, vestibular fornix, right? They are non-keratinized. And specialized mucosa is mainly keratinized. So gingival epithelium is basically parakeratinized. So our answer, we have got the answer for our question, right? Now, gingiva is mostly parakeratinized in 75% of population. It is keratinized in 15% of the population and non-keratinized in 10% of the population. Coming to the parts of gingiva, right? Cole. What is cole? Cole is basically the portion of interdental gingiva connecting the buccal and the lingual portion of the tooth, right? So this cole is mainly present in the interdental portion of the gingiva connecting the buccal and the lingual portion of the tooth. It is mainly non-keratinized. Then coming to sulcular epithelium, it is also non-keratinized. Junctional epithelium, it is also non-keratinized. This junctional epithelium has high rate of turnover. Coming to hard palate, it is orthokeratinized. So masticatory mucosa is basically keratinized, and amongst it gingiva is mostly parakeratinized, while our hard palate is orthokeratinized. Now next question was regarding dental anatomy. Basic terminologies of dental anatomy. How to differentiate between ridge, fossa and groove. This was one of the question asked from dental anatomy. Ridge, fossa and groove. So what is a ridge? Ridge is basically a linear elevation on the surface of the tooth. Linear elevation. It is not depression, it is elevation on the surface of the tooth and is named according to its location. Being it a buccal ridge present on the buccal surface, lingual ridge present on the lingual surface, marginal ridge on the margins of the tooth. So from this diagram you can easily appreciate the ridge. Here we can see this elevated portion present on both the sides of the lingual fossa are our marginal ridges. On mesial side we will have mesial marginal ridge, on distal side we are having distal marginal ridge. So these are basically elevated portion, not depressed portion. Here we can see this is also elevated portion. This is ridge, this is ridge, this is ridge, and this is also our ridge. So these are the triangular ridges. This will be the cuspal ridges, right? Present on the cuspal portion, the elevated portion. So these are the ridges. Present on the margins, they are known as marginal ridges. So based on their location, they have their names. So basically ridge is a linear elevation which we have seen. This elevation, if it is present on the buccal surface, mostly in canine you can have a buccal ridge, in premolars you can have a buccal ridge, right? And lingual ridge. In canine we have a lingual ridge separating two fossas, mesial and distal fossa in case of canine. Now what is fossa again? So ridge is basically elevation. Fossa is depression. It is depression. So mainly fossa will be irregular depression or concavity. It is irregular depression or concavity, right? So ridge is elevation, fossa is depression or concavity. So here, what is this? Is this ridge or fossa? This is basically our fossa, lingual fossa. This is the depressed portion we are seeing, right? So the depressed portion or the concavity present is fossa, while our elevation is our ridge. Here also we can have triangular fossa present on the side of the ridges, marginal ridges. Mesial triangular fossa, distal triangular fossa, we can have central fossa, right? Here in this diagram, we can easily appreciate this is the depressed portion, which is fossa, lingual fossa. This will be the marginal ridges, right? Coming to the central fossa. So this depressed portion is central fossa. On the sides we have triangular fossa. Here we can see, easily appreciate the triangular fossa. So ridge is basically linear elevation, while fossa is our depression. So there should not be now any doubt in the terminology such as ridge or fossa. It might be now clear, right? Groove. Now groove again is a depression. It is a shallow line between the primary parts of the crown or the root. Shallow line means again it is a depression. It is line type of a thing. Depressed line. So this will be our central groove. This is our premolars, right? Then we can have the line extending towards the buccal surface will be buccal developmental groove. Toward the lingual surface will be lingual developmental groove. Towards the mesial surface, mesial developmental groove. Towards the distal surface, distal developmental groove, right? So here we can see mesial developmental groove, distal developmental groove, right? We have mesiobuccal developmental groove, distobuccal developmental groove. This will be our lingual groove, right? Now coming to this, these are the supplemental grooves, extra grooves, which are mostly present on which tooth? Supplemental grooves are mostly present on maxillary, permanent maxillary, second premolars, right? It is a characteristic feature. It has a wrinkled surface. This maxillary second premolar mostly has a wrinkled surface because of the presence of supplemental grooves. So again we are done with our second question, which was from dental anatomy for basic terminologies. How to differentiate between ridge, fossa and groove. Ridge, remember, it is an elevation, not a depression. So ridge is basically elevation and its name is basically on the location. Now coming to fossa, it is a irregular depression or concavity. Groove, it is mainly a shallow line separating the cuspal portions mostly. This groove can be present in root also, right? On root also, this type of depression may be seen. Which characteristic groove is present on the mesial surface of maxillary first premolar? This is characteristic of maxillary first premolar. So which groove will be present? Mesial marginal developmental groove is present on the mesial surface of maxillary first premolar, crossing the mesial marginal ridge and extending to the mesial surface of the premolar. Now next question was, what is osteodentin? Now during tooth development there might be some disturbances, right? So if due to some deficiency such as vitamin A deficiency, what will happen? Amyloblast cells fail to differentiate properly. Usually, how is our hard tissue formed? Enamel and dentin, they are formed by reciprocal induction. Formation of dentin and enamel is basically interdependent, not independent, right? So if inner enamel epithelial cells differentiate into amyloblast cells, then these cells will send signal to dental papilla cells, so that the dental papilla cells differentiate into odontoblast cells and form dentin. Once dentin is formed, it will give again signal to the amyloblast cell, which will help in formation of enamel, right? So basically amyloblast provide signal to dental papilla cells, which differentiate into inner enamel epithelial cells, differentiate into amyloblast cells, which provide signals to dental papilla cells, which differentiate into odontoblast cells, right? And this odontoblast cells will form dentin. Right? So once dentin is formed, it will again send signal to amyloblast cell, which will lead to formation of enamel. So formation of dentin and enamel is basically interdependent. So if our amyloblast cells are not differentiated properly, then what will happen? It will not send proper signals to the dental papilla cells to differentiate into odontoblast cells, right? So their organizing influence on the adjacent mesenchymal cells is basically disturbed, as a result of which it will lead to the formation of osteodentin, right? So basically it is defect in differentiation stage, histodifferentiation you can say, right? So if amyloblast cells fail to differentiate properly, then its organizing influence on dental papilla cells will also be influenced, as a result of which atypical dentin will be formed, and this atypical dentin is our osteodentin. So atypical dentin will be osteodentin. Now coming to our next question. Lamina dura has increased mineral content? This was the basic question which was asked. So basically, what is lamina dura? Radiographically, a bundle bone is referred to as lamina dura. It appears radio opaque. This lamina dura will appear radio opaque. Why? We have seen the structures which have increased mineral content usually appear radio opaque, but here basically it is due to the presence of thick bone without trabeculations that the X-rays must penetrate. So basically this radio opacity is because of the thick bone with trabeculations and not due to any increased mineral content. Mineral content will be there, same as that in bone, right? But basically it is due to the presence of thick bone without trabeculations. Content will be the same. And bundle bone, it is a bundle bone which provides attachment to the periodontal ligament fibers. Now coming to our next question. It is a good question. Difference between Tom's process, Tom's fibers and Tom's layer. Okay. So basically these three terms are different. Don't correlate these three terms, right? Difference between Tom's process, Tom's fibers, and last one is Tom's layer. So these three terminologies are basically different, right? So now coming to what is Tom's process. TOMS process is mainly seen in the secretory stage of amyloblasts, right? They are basically small pyramidal cytoplasmic extension from the distal end of the amyloblast cell. They basically play an important role in formation of enamel rod. So here we can see this pyramidal shape structure. This is our TOMS process. It is basically a picket fence appearance. It has a picket fence appearance. Picket fence appearance. Why? Once enamel is formed, first layer of enamel is laid down, what will happen? The amyloblast cells will develop a distal extension, right? This is the proximal end of the amyloblast cell. This is the distal end of the amyloblast cell, right? So this is the distal end of the amyloblast cell. From this distal end of the amyloblast cell, we will have a small pyramidal cytoplasmic extension. And this cytoplasmic extension will lay down enamel rods. This will be the distal end of the distal junctional complex of the TOMS process, and from the proximal end we will have interrod substance, right? So from the proximal end of the amyloblast cell, interrod substance is formed, while after the formation of the TOMS process we will have enamel rods. So the first formed enamel, usually it will have absence of enamel rods. It will have absence of enamel rods. So TOMS process is basically distal extension of amyloblast cells, which helps in the formation of enamel rods. From the distal end of TOMS process we get enamel rods, and from the proximal end we will get interrod substance. Remember this. So basically it is an extension. Once enamel matrix is laid down, the amyloblast cell will move towards the proximal end and extending its distal portion. So this is helping in the formation of enamel rods. Here in this diagram we can easily appreciate that this is the distal end, this is the proximal end, right? So from the distal end we are getting enamel rod, and from the proximal end we are getting interrod substance. Okay, so it is the distal end for rod and proximal end for interrod substance. Now coming to TOMS granular layer. One question was, what is the difference between TOMS process, TOMS granular layer and TOMS fibers, right? So TOMS granular layer. What is TOMS granular layer here? This is the TOMS granular layer. Granular word itself says it has appearance of granules, right? This is our cementum, this is our dentin, and between that we have our TOMS granular layer. So basically it is present in the root portion, obviously, starting from the cemento-enamel junction towards the apex of the tooth. So it is starting from where? Cemento-enamel junction towards the apex of the tooth. It increases basically from CJ towards the apex. It has granular appearance. It is mainly a hypomineralized structure. It is a hypomineralized structure. So why this appearance is granular? Why is it appearing granular? It mainly appears granular because of coalescence and looping of dentinal tubules. This tubules, mainly banding of the dentinal tubules. So it has granular appearance mainly because of coalescing and looping of dentinal tubules. So this is Tom's granular layer, which is usually present in the root portion beneath the dentine portion, right? It usually starts from cemento-enamel junction towards the apex of the tooth, and it is mainly present because of coalescing and looping of dentinal tubules. It is a hypomineralized structure. So Tom's process is basically from enamel portion. Enamel part, basically it is involved in the formation of enamel. Tom's layer, it is basically in beneath the dentine. So this both are obviously different, right? Now coming to Tom's fibers. What are Tom's fibers? Tom's fibers are basically odontoblastic process. They are basically odontoblastic process. Okay. So they are known as Tom's fibers. So what are odontoblastic processes? Cytoplasmic extension of odontoblast cell. If this is our odontoblast cell, this extension of odontoblast is known as Tom's process or odontoblastic process. This is usually present in the dentinal tubules, right? So basically Tom's fibers are odontoblastic process, extension of odontoblastic cells that occupy the dentinal tubules. Here we can see odontoblast cell and its extension. Okay. So it is mainly odontoblastic process having cytoplasmic extension of odontoblast and occupies the dentinal tubule. So this is a part of odontoblast cell, right, which are present near the pulp dentine border. After the formation of dentine, they move towards the pulpal region having their extensions. So what is basically the difference between Tom's process, Tom's fibers and Tom's layer? We have also solved this question. Tom's process is basically involved in the formation of enamel rod. Tom's fibers are basically extension of odontoblast cells, and Tom's granular layer is basically present because of coalescing and looping of dentinal tubules. Now coming to next question. What is primary enamel cuticle and what is secondary enamel cuticle? So you get a MCQ question obviously from this Nischmidt's membrane, right? So what is Nischmidt's membrane? It is basically a delicate membrane that covers the crown of newly erupted teeth. It covers the crown of newly erupted teeth, which is removed later by mastication. So this primary enamel cuticle is basically our Nischmidt's membrane. It covers the crown of newly erupted teeth. It is basically a basal lamina. It is a basal lamina secreted by the amyloblast cells when the enamel formation is completed. So it is basically what? It covers the crown of newly erupted teeth. It is primary enamel cuticle. Primary enamel cuticle is also known as Nischmidt's membrane, and it covers the crown of newly erupted teeth, usually removed by mastication. It is a type of basal lamina secreted by amyloblast cells. Amyloblast secreted by amyloblast when the enamel formation is completed. So what is its function? It is a covering, obviously. So its function is mainly to protect the enamel. From what? This enamel will be initially surrounded by connective tissue, right? Vascular portion. So from the resorptive activity of the vascular tissue prior to tooth eruption, before the eruption of tooth in the oral cavity. So basically, Nischmidt's membrane is primary enamel cuticle covering the crown of unerupted tooth and protecting it from the surrounding connective tissue, resorptive activity of the surrounding vascular tissue prior to its eruption into the oral cavity. Now coming to secondary enamel cuticle. Now here, this is our tooth. It is usually covered by reduced enamel epithelium, right, before the eruption of the tooth. But in the cervical portion, here, there will be retraction of reduced enamel epithelium. So, because of this, the dental follicle or the connective tissue cells come in contact with the enamel, formed enamel. And as a result of which, in the cervical portion, sometimes there is deposition of cementum. Sometimes there is deposition of cementum because of the retraction of the enamel organ from the cervical portion. This leads to the formation of afibrillar cementum, which we have discussed in our live lectures also, in our recorded lectures also, right? So basically, because of the retraction of the reduced enamel epithelium near the cervical portion, what will happen? There will be deposition of cementum. As the dental follicle cells come in contact with the newly formed enamel, they differentiate into cementoplast cells and lay down cementum. And this cementum is basically afibrillar cementum, which you can consider as a secondary enamel cuticle. Now next question was, at what stage of Nulla stage tooth erupts? So basically there are different stages, right? Initially there is absence of crypt, then first there is presence of crypt, then we can see initial calcification. In the third stage we can see 1/3 of the crown completed. In the fourth stage we can see 2/3 of the crown completed. Fifth, crown almost completed. Sixth, crown completed. So in sixth stage we can see what? Crown is completed, right? So here you can say tooth formation has initiated, almost crown is completed. Then as root is forming, the tooth starts to erupt in the oral cavity. It doesn't wait for full root to form. As the root formation starts, the tooth starts erupting in the oral cavity. So this can be a stage where tooth erupts in the oral cavity. Then we can say 1/3 of the root completed. 8th, 2/3 of the root completed. 9th, apical end of 9th, root almost completed. But the apical portion is open here. And in 10th stage we can see apical end of the root is closed. Right. So basically on this stages also you can estimate the age. Now someone had a question regarding the image based question for age estimation, right? So if you are given this type of image, always look for the last tooth to erupt in the image. Last tooth to erupt means here we have, these are the deciduous tooth, right? The white one are the permanent tooth. So which permanent tooth are present? Basically we have central incisor is erupting, right? Permanent central incisor, both central incisors are present. Now coming to lateral incisor, mandibular lateral incisor is present, but maxillary lateral incisor has not yet erupted. We can see the presence of deciduous lateral incisor here. Now here rest are our deciduous tooth, deciduous canine, deciduous molars. This we have our permanent molars. These are our permanent molars. So basically the age will be, which is the last tooth here? Molars? No, they are the first to erupt, right? Central incisor? No. So remaining is our lateral incisor, mandibular lateral incisor. So the age of the child will be based on the age of eruption timing of lateral incisor. So what is the eruption timing of lateral incisor? We are having mandibular lateral incisor, right? So it is 7 to 8 years. It is 7 to 8 years. So basically the age of the child will be 7 to 8 years. So always look for the last tooth to erupt. Right? In this diagram also we can see central incisor have erupted, maxillary central incisor. Canines have not yet erupted, premolars have not yet erupted. So basically here we will have maxillary lateral incisor. So what will be the age of eruption of maxillary lateral incisor? 8 to 9 years. Right. So this type of questions are basically asked for your image based questions. Now someone had asked me regarding the location of the papilla. One diagram was asked and they were asking which papilla is present here, right? So basically based on location also you can be asked an image based question. Identify the papilla showing arrow. So it is basically circumvallate papillae because they are present in front of V-shaped sulcus terminalis. Foliate papillae, they are present in the posteriormost part towards the lateral border. Fungiform papillae are usually present between the filiform papillae. Filiform papillae usually do not have any taste buds. They are mainly present on the superior portion of the tongue, near the tip of the tongue. So based on the location also you can be asked image based question for papilla. Histologically, so you can be asked only, here you can see cone like projection. So this is basically filiform papillae. Fungiform papillae is basically mushroom shaped present between the filiform papillae. These are our foliate papillae. So main questions we have answered. Someone asked me regarding the tips for studying the tooth morphology, right, in dental anatomy. So for dental anatomy, you should be thorough with the chronology table, right? Permanent dentition as well as primary dentition. Eruption timing of permanent tooth as well as deciduous tooth. Next is you should be thorough with the tooth numbering system for dental anatomy. Tooth numbering system is also very important. Now coming to morphology. How to study the morphology of the tooth, right? So always remember the characteristic features of the tooth. maxillary central incisor, it is wider mesiodistally, right? It has a W-shaped fossa. Labial surface, if it has any characteristic feature on labial surface, if it has a characteristic feature on lingual surface. So mamelons can be present on incisors because they usually develop from lobes, right? 3 lobes. Usually anterior tooth are developed from 4 lobes. 3 are involved in formation of buccal surface, 1 in the formation of lingual surface. So you can say incisors usually have mamelons. During the eruption timing, with age they wear off. W-shaped fossa. Then they have cingulum, root, single rooted tooth, right? Then coming to lateral incisor. Lateral incisor has characteristic feature of what? Palatoradicular groove. In the lingual portion, there is a groove present extending from the crown towards the root, which is palatoradicular groove. So this you can remember, characteristic feature for lateral incisor. Coming to mandibular central incisors, they are usually bilaterally symmetrical. Bilaterally symmetrical. Both the surface, mesial and the distal surface, are usually similar. So this is the characteristic feature for mandibular central incisor. Coming to mandibular lateral incisor, it has slightly a distolingual twist is present. So this is the morphology, basic characteristic feature of the morphology of the tooth, which can be asked as an MCQ question. Then we have canine, so which is the longest tooth. Maxillary canine has longest root, right? Then coming to premolars. Premolars, which premolar has 2 roots? Maxillary first premolar. So always be thorough with the roots, the surfaces, cusp. If cusp are present, now coming to the premolars, usually all the premolars have 2 cusp. So which premolar has a 3 cusp pattern? Mandibular second premolar will have a 3 cusp pattern. So this is the difference, basic difference. Mesial slope is longer in which tooth? So maxillary first premolar. Always be thorough with the characteristic feature. Rest of the thing you can write. And if you are asked long note on based on your university exams or some other exams, always go with the surfaces. Labial surface, lingual surface, mesial surface, distal surface. So labial surface is convex, mesial surface is what? How is the mesial surface? Convex, then concave. So basically you should be thorough with the diagrams of the tooth as well. And always remember how many cusps are there in a tooth, which tooth has how many cusps, how many roots are present, characteristic feature, cusp of carabella is present in which tooth, maxillary first molar, what is oblique ridge, it connects which cusps, it is present between which cusp. In maxillary first molar, acute angle is formed by which cusp, obtuse angle is formed by which cusp, right? Plus pattern is seen in which tooth? Mandibular second molar. 5 cusps are present in which tooth? Mandibular first molar, right? And one question was regarding shedding of tooth. So we have already discussed in our live and recorded lectures also. You can go through that. But basically shedding. Someone has asked regarding shedding of tooth. What is shedding of tooth? So it is basically removal of the deciduous tooth and replacement by permanent tooth in their functional position. So once the deciduous tooth shed off, our permanent tooth takes its position. So mainly this shedding is caused by resorptive activity of the tooth germs. Our permanent tooth germs in the anterior region are present lingually to the roots of the deciduous tooth. This tooth germ will exert pressure on the roots, which will start the resorption of the root. And in the posterior teeth, usually they are present between the roots, right? So as they are present between the roots, they exert pressure on the roots here, and then they start the resorption of the root. Here resorption of the roots take place, and then in crown portion resorption of the crown will take place. Okay. Mainly this resorption is caused by what? Odontoclast cells. Odontoclast cells. This odontoclast cells are mainly multinucleated cells. This odontoclast cells resemble our osteoclast cells, right? So they are multinucleated. They are TRAP derived cells, tartrate resistant acid phosphatase circulating monocytes. They are derived from TRAP, tartrate resistant acid phosphatase circulating monocytes. So they are basically multinucleated TRAP circulating monocytes. So they resemble which cells? Osteoclast cells. Their basic structure as osteoclast cells. So basically osteoclast is involved in the resorption of bone. Same way odontoclast are involved in the resorption of the hard tissue, root portion. Resemble osteoclast cells. So this odontoclast cells attach to the tooth surface, right? Root surface. They secrete what? H plus ion. They secrete H plus ion. They create acidic environment there, which leads to the mineralization of the structure, right? So they release what? H plus ion. They create what? Acidic environment, leading to the degeneration of the tooth structure. So they get attached to the tooth through their sealed portion and they release H plus ion, which are then the broken materials are digested by the cytoplasmic vacuoles. So basically shedding is removal of the deciduous tooth and the permanent tooth taking their functional position. And this removal of deciduous tooth is basically a physiologic phenomena, not a pathologic phenomena. In permanent tooth, if the permanent tooth shed off, it is mainly because of some pathological condition, right? Periodontal disease, some cyst, some tumor, right? But here, deciduous tooth basically shed off because of the erupting force from the permanent tooth germ. And the odontoclast cells are involved in the resorption. So this is basically the shedding portion. And in detail we have discussed in our lectures. So major of your doubts are cleared. Right. So thank you. And good night. We'll meet in our next session now.